And welcome to the Dr. Bob Show. We stress on the Dr. Bob Show that you should get yearly eye exams. The eye doctor can look in your eyes and he can find out if there's increased pressure in your eyes, if you're getting cataracts, the back of the eyes, if there's problems with the retina. They can actually diagnose diabetes and high blood pressure. An eye exam is so important to your regular health. But what if there are problems on the outside? What if something happens to the orbit itself? What if there's a fracture there from an automobile accident? What if there are lacerations? What if there are problems with the lids? What if there's problems with the tearing? What do we do about that? Are there times where special surgery is needed in order to protect your vision? We'll be spending most of the show talking about that. My guest is Dr. Anzeljc, wonderfully trained, board-certified ophthalmologist who does oculoplastic. That's taking care of the unusual things that might happen. He'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about the importance of women in our society, especially after the age of 40, and what they need to stay healthy. Women are frequently nurturing and self-caring, and they take care of everybody else. But now with their importance in our society, women need to learn what it takes for them to stay healthy. And there are several things we're going to learn on the Dr. Bob Show. You'll want to stay tuned. It's going to be an exciting show. We're talking with Dr. Anzeljc, and we're talking about special problems that occur with the eye and what it takes to keep your eye health good. We've only got two eyes, need to take care of those. Andy, welcome to the Dr. Bob Show.
Dr. Bob, thank you for having me today. I appreciate it. It's an honor.
It's great to have you here. Tell me about oculoplastics. Now, what is your training in ophthalmology?
Sure. So in oculoplastics, true certified oculoplastic surgeons will go through ophthalmology residency after completing medical school and an internship in either medicine or surgery. And following that, they will undergo a 1 or 2 year fellowship with further training in oculoplastic surgery, which is our shorthand for ophthalmic, plastic, and reconstructive surgery. All that really means is that we specialize in fixing problems with the eyelid, eye socket, and tear duct.
So anything sort of on the outside, you might say. So let's talk about some of the problems that you deal with most. Let's talk about the eyelids. What goes on with the eyelids that cause problems?
Sure. The most common problems with the eyelid by far are droopy upper eyelids. That could either mean the skin of the upper eyelids is hanging over, and we call that dermatochalasis or dermatochalasis, or that the eyelid margin itself is droopy, indicating that that's a ptotic lid. The other common eyelid problems include ectropion or entropion, which are just where the lower lids, or sometimes even the upper lids, can be turned outward or turned inward in the wrong direction, which could be irritating to the eye itself and the ocular surface.
So let's go back to the upper eyelid. In my upper eyelid, like my father's, it sort of folds over, and I can make it look where it's blocking my vision. Is that what happens sometimes, and you need to take away the extra skin that's there, or what do you do?
So, although that surgery is very commonly performed for cosmetic reasons,
yes,
oftentimes, very, very commonly, especially with older age, patients have so much extra skin that it interferes with their vision, especially while doing daily activities like driving, reading, even watching TV. If that is the case, if you feel like the skin is blocking your vision, oftentimes insurance will pay for the blepharoplasty surgery to correct that problem.
So how do you test whether that little fold of eye is actually interfering with somebody's vision and they can't see as well?
So the first thing to do is to have a complete eye exam by an eye care provider. If everything else checks out and the only thing that they really notice that's interacting with your vision is that extra skin, the best thing to do would be to have an evaluation by an eye surgeon, either an ophthalmologist or an oculoplastic specialist, who can go ahead and do a few tests in the office just to measure the amount of skin hanging over and how that's interacting with your eye. They'll also take some photos and perhaps do a visual field test to determine if this is truly visually significant.
So if there's a visual problem because of the extra skin, because it's older and it flaps down over the eye that's there, what kind of results do you get? I mean, what does the patient tell you afterwards?
So usually immediately after the surgery, the patient will tell me that they can see better and they see more light coming in and better peripheral vision. And then at least at the follow-up visits, they're already saying what a significant difference they have even while they're swollen after the surgery.
You mentioned the word ptotic eyes. There are some eyelids that actually the whole eyelid comes down further on one eye than the other, and there are some medical problems that cause that. So what do you do with ptosis?
That's correct. Assuming there are no underlying medical problems that need to be addressed, if it's just truly an age-related change, which can happen in some individuals, then that is another situation where typically surgery is indicated. Although there are some ways to avoid surgery, the definite procedure to fix it is a surgical operation, and you can either go from the outside, where you make an incision on the outside of the eyelid, or from underneath on the inner surface of the eyelid, and basically work on the muscles that lift the eyelid to help them start at a higher point.
I would think, and I don't hear of that surgery being done much. We see people with ptosis where the lid falls, and that means there's less of the white of the eye that you see. Mm-hmm. Is it easy to get those muscles to work back? Is it really touchy? Is it something you try to avoid?
Having done an oculoplastics fellowship, I feel very comfortable doing that type of surgery, and that's something I do all the time. I would say that it's pretty easy to get the lid higher up in most cases. The most delicate part of the surgery is symmetry, because obviously not everybody's made symmetric, and we're not born that way, and it's hard when somebody operates on you to get that symmetry just perfect, because once it's been touched by someone else, patients tend to notice a little bit more. So.
If you've got ptosis, is it usually just on one side? So if one lid is falling down, is it usually one side, or both of them can be falling?
Now, usually ptosis is a bilateral process. It means both sides are involved. However, it is not completely unusual to have it affect one side and not the other two.
Lower eyelid. A lot of people get puffy lower eyelids. Some people get to where the eyelid falls out. You called it ectropion, I think.
Ectropion, that's correct. That's where the eyelid margin itself, that's the basically top or the edge of the eyelid, is turned outward away from the eye. And that could lead to multiple problems, including drying out of the eye, but it can also lead to tearing, where tears are pouring down the cheek, because the tear drain sits in the middle corner of the eye, and that helps drain the tears away from the eyeball. If that's not in the correct position, tears are going to well up and then overflow down your cheek.
So is it an easy problem? What do you do to fix an eyelid that's falling down, I guess, the lower eyelid?
So with ectropion, with the eyelid turned out or fallen down, the most common surgical procedure is an ectropion repair, in which we make an incision on the outer corner, that's about here on the eyelid, and we essentially are tightening the eyelid horizontally. The most common cause of that turning out of the eyelid margin is a laxity of the eyelid. So if we tighten it, we usually get a great surgical result.
I've heard of a loop procedure. What's a loop? Is there a loop procedure for the lower eyelid?
So the real procedure for the lower eyelid is actually a lateral tarsal strip, and that may be something along the lines of what you're referring to.
Lateral tarsal
strip.
What does that mean?
That is just taking that lateral tarsus, which is basically the fibrous plate that is the structure of the eyelid margin, and making a strip of it at the outer corner and pulling it and reattaching it to the bone at the outer corner of the eye socket. That's what gives you that tightening in that ectropion repair.
So if people have an ectropion, the eyelid falls out, does that make them more predisposed at nighttime to have dirt or stuff that's flying around the room to get in the eye and cause scratching of the cornea and causing some damage to the eye?
It certainly can if you have what we call nocturnal lag ophthalmos. That's just a fancy word for nighttime opening of the eye. That means when you're sleeping or when you're napping and you try to close your eyes, they may be cracked open just a little bit. And that could be the result of ectropion, although it could happen with other problems as well. If that's the case, certainly dirt and debris can get in the eye, but the more important thing is the eye dries out because the eyelids aren't protecting it, lubricating it, and that can be a major issue.
You know, sometimes we take the eyes for granted, but there's always something that can go wrong with any part of our body. It seems to me like being able to fix the problems, the falling eyelid, the eyelid that droops down, the problems that people have, would be just very, very thrilling to be able to help people with that.
It is. It's very exciting and it's very rewarding at the same time. Obviously, attention is immediately drawn to your eyes. When you're speaking with someone, you're automatically drawn to their eye appearance as well as their eyelid appearance. And so not only are a lot of these problems functional for patients, but cosmetic as well, and they really can change your appearance.
Are there problems with the eyebrow?
Of course.
And that's what we're going to be talking about when we come back. Of course there's problems with the eyebrow. Well, what kind of problems, and how do we fix them, and what's going on, and what happens if we don't fix them, and what if something, we have just puffiness? How do we get rid of puffiness in the eyes? I'm beginning to understand oculoplastics and how important they are in making you look good, but fixing the problems that are making it where you can't see well. You're going to want to stay tuned. We're talking with Dr. Andrew Anzeljc, and we're talking about oculoplastic surgery. We were talking about lid problems, upper eyelid, lower eyelid, problems with eyelids that fall, and the surgery that's needed to correct those if you've got a problem so that you won't get further eye problems. Then we started talking about lacerations. So let's talk about lacerations. If somebody gets cut across the face, let's say they get in an automobile accident and they get a laceration there and maybe even trauma to the eye. What do you look for and what do you see?
Sure, so number one thing to do in that case is to have the whole trauma survey, of course, and make sure there are no other corresponding injuries. But regarding the eyes and the eyelids, specifically in the eye sockets, you want to first rule out any injury to the eyeball. The eyeball is the most important structure for your vision, of course, and so without that, we're not doing you any good. If everything is okay with the eye, including a full exam, there's no retinal problems, no what we call open globe, which is damage to the eye itself, then you evaluate the eyelids and the eye sockets. So the eyelids, you look for any cuts or lacerations. And the important thing there is that the eyelids help protect the eyeballs. When the eyelids close, they lubricate the eyes, they spread your tears over the cornea and help with our vision. But they are the main protective mechanism. And so if there is a cut, it needs to be addressed appropriately so there aren't any deformities with the eyelids, and also so that they do their job the right way. The other issue with the eyelids is that in the corner by the nose of each eyelid is a little opening, and that drains into your tear duct. And so you want to make sure there are no injuries that could lead to problems with chronic tearing afterwards. And finally, just around the eyeballs are the eye sockets, which are the bony structures the eyes sit within.
It's getting more and more complicated.
It is.
And things that can happen. So where are the tear glands?
So the main tear glands that people think of are the lacrimal glands. Those sit in the upper outer corners of the eyes.
And then they wash the eye.
And then tears bathe the cornea, they bathe the eye, and they exit toward the middle and then into the nose, essentially, through a duct.
So the duct goes from the eye into the nose, those main ducts.
Correct.
So if there's something going wrong there, what goes wrong with the eye ducts, with the drainage area?
The most common problems we see are that over time, those can get blocked up. And that could be just a normal change over time for some individuals, or it could be the result of either infections or other inflammatory processes. The end result, if there's a blockage, usually anywhere through the tear duct, is going to be tearing. And this is not the type of tearing typically where your eyes get a little watery. This is where tears are really pouring down your cheek.
Yeah,
and
usually one side?
It's usually one side, although a lot of people do have bilateral as well.
So you've got a little duct there that's blocked, and so the tears can't go down, so they come out on the face. How do you unplug that duct?
The most common level of age-related change and blockage of the tear duct is at the junction between the sac where tears collect next to the nose and in the duct that actually travels through the nose. The usual place to fix that, or the usual surgery to fix that, I should say, is what we call a DCR. That's dacryocysto-rhinostomy.
That's a big long word.
Fancy word for basically doing some plumbing.
Plumbing on that very important duct.
Plumbing on that duct. So what we're doing is basically bypassing drainage through that duct into another route through the nose, and that can either be done with an external excision on the skin or through the nose in what we call an endoscopic DCR.
So I'm going to go back to that automobile accident where we had trauma to the eye, where we had cuts to the eye, where you examined the eyeball and it was okay, and the muscles that supply the eye. And what if there's a fracture? So can you break the bones around the eye?
Fractures around the eye, or orbital fractures, are very common. The most common type of fracture is what we call a blowout fracture.
What's that, blowout?
Blowout really means the orbital floor, and sometimes the medial wall, which is the middle wall by the nose, can, because of the pressure from the rapid expansion of pressure in the eye socket from a trauma or from a direct injury to the bone surrounding the eye socket, you can get the floor, or the bottom bone, to expand or go down into the sinus that sits underneath it. Wow. Hence the floor blows out of the eye socket.
Is that a thick bone, or is that a paper thin bone, or is it in between bone, or tell me about that?
It is an extremely thin bone. So the average thickness of the bone of the eye socket that's on the floor is around 0.4 millimeters thick, 0.4 to 1 millimeter thick.
So that's really, really thin. So as you're banging against the eye, the pressure that's put back against the eyeball can blow out that little thin bone that's behind it, or on the floor, as you say.
That's correct, and that can lead to a few different problems, one of which being entrapment of one of the muscles that moves the eye specifically down, called the inferior rectus muscle, and that could lead to double vision. If the fracture is large, it could also lead to the eye appearing sunken in as well.
So how in the world can you fix that, or how do you tell if that muscle has been damaged, or that it's not moving the eye properly, or that there's a fracture in the how do you fix it? To me, it's getting where you need to get an oculoplastic surgeon.
Sure, so this is an area that a lot of physicians can handle, and you do want to have an eye exam to make sure there aren't any problems with the eyeball itself. But once that's done, you evaluate each patient on a case-by-case basis. It's nice to have a CT scan with thin cuts through the face or through the orbit specifically to evaluate the fracture. But telling whether or not there's true entrapment of that muscle is really a clinical diagnosis. It's something that a physician has to look at. They'll check your eye movements in all directions, and then if you're not moving your eye upwards appropriately, that usually means that that one muscle is trapped, or at least pulled down into the defect. Now, if that's the case, they may have to do another test. We call that forced ductions, where we're trying to force the eye up to see if it's trapped or if it'll move. Once we've established that there's a fracture, and if we decide that it does need to be repaired, and this is either an oculoplastic specialist, oral maxillofacial surgeon, ear, nose, and throat physician, or a plastic surgeon, we would often go in through the eyelid and elevate all of the contents of the eye socket that have gone into that defect or into that fracture, take them out, and then usually put a little implant or a plate underneath to support them so they don't go back down.
When you have a blowout fracture like that, how often is the surgery successful, or how often does it lead to blindness?
So blindness is a very, very rare and very feared complication of the surgery. I would say it's very, very unlikely if in the hands of a good surgeon who's comfortable working in the eye socket. If you have to have a fracture repaired, it is usually very successful. It's a procedure that's very effective and has very good results in the end for the patient.
What I'm hearing you say is basically the eye is so important. There's so many things that can go wrong, but they can all be fixed with the proper technique, with the proper training, with the ability and the knowledge to take care. It amazes me what you can do. It really does. And so those 2 years. You did those at Emory, your oculoplastic, furthering your education?
That's correct. After completing a 3-year residency in ophthalmology, just training to do surgery within the eye, I spent 2 extra years basically trying to avoid being inside the eye and doing everything around the eye and eye socket and tear duct, and that was all at Emory.
As we were talking earlier, a lot of the work can also be for people that have facial problems. There are things you can do to fix that also. A sunken face and eyelids that are not where you want them to be. Thank you so much for coming to the Dr. Bob Show. Thank you for teaching us. Thank you for letting us know that if there's something going wrong with the eye, that we can fix it. Outstanding teaching.
Thank you very much. Thanks for having me, Dr. Bob.
Wow. It's a lot of information. And I think the basis to that is, in medicine, we're getting better and better at being able to fix what's wrong. If you've got something wrong with your eye, or somebody in the family, know that your eye doctor can guide you toward what needs to be done for that to be fixed. And if you need the care of an oculoplastic surgeon because you need something special, it's available for you. Now you're going to want to stay tuned. We're going to be talking just a minute about women over the age of 40 and how important it is for them to stay healthy so that they can take care of the world. You'll want to stay tuned. I want to thank Dr. Andrew Anzeljc's wonderful discussion on problems that can go wrong with the eye that can be fixed. And now from questions from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, I'm 46. I've got 2 children. I need to stay healthy. I don't have time to stay healthy. What do you recommend? It's a good question. Women have been so important in our society. They're naturally caregivers. They take care of everybody else. They take care of their children. They take care of the house. They take care of their husband. And now they're getting a very important part of our society about being CEOs of businesses, about running for political office. And now they've added on to what it takes for them to be a solid person. So what can they do to stay healthy? Because women have to look after themselves. So let's go through some things. Number 1, be careful with alcohol and smoking. If you smoke, you need to stop. Every time we inhale, it damages the lungs, it damages the blood vessels, it gives us upper respiratory infections, and we don't stay healthy. It will cause wrinkles and other things, but smoking is extremely dangerous. Watch your alcohol. Alcohol, more than 1 drink a day, leads people to have lots of medical problems. It can damage the liver, it can cause problems with sleep and with your health. There are heart problems that go along with too much alcohol. There's increased breast cancer and colon cancer, so be careful, cut down on alcohol. And then breast health. We're so good now at diagnosing breast disease. And so if you catch breast cancer early by mammograms, by examination, then if we find it early, your chances of a cure are 99%. So be sure that you get mammograms regular. Start at age 40, unless your family history says you should start a little bit early. Talk that over with your doctor. And then we get mammograms every year or every other year. You know, that depends on you and your doctor and your family history. Pay attention to those things. As far as the cervix and the uterus go, we need to have a pelvic and a pap smear done every year or every 2 years, again, depending on your history, on your family history, on what your doctor tells you. The diseases that we can find OBGYN are so important to your health. When we go down to other areas, a colonoscopy at age 50, unless your family history says colon problems, colon cancer, colon disease at an earlier age, then you need to start earlier. If we have a colonoscopy at age 50, the doctor finds an adenomatous polyp. If he removes that, then the chances of you getting colon cancer go down to almost nothing. And so it's a preventable cancer. Heart protection. Women have different heart symptoms that men do. They need to know what their cholesterol is, the good cholesterol and the bad cholesterol and the triglycerides. So know what your bloody fats are. Know what your blood pressure is. Be sure that your blood pressure is not high. Talk to your doctor about your heart if you have any symptoms of chest pain or unusual symptoms with activity. Talk to your doctor about that. Vaccinations, you need to be sure that you follow recommendations on vaccinations. You need to get pneumonia shot. There's now 2 pneumonia shots. There's a Tdap, that's tetanus, diphtheria, and pertussis. You get that, and then 5 years later, you just have to get the TD shot, your shingles shots. So talk to your doctor about vaccinations. A whole lot of things that you can do to stay healthy. That's all the time that we have for this show. Is you're writing those things down on health. Know that we need to be exercising. We need to get 7.5 hours sleep to feel good. We need to eat properly, eat less food, but eat better foods. And most of all, what is it we want? It's that laughter in your life. Take time to enjoy yourself. When you enjoy yourself, sit down and tell fun jokes with somebody and laugh and giggle a lot. Because when you giggle, your immune system works better. You'll stay healthier, and you and the people around you will be happier.